So I am waiting for the raise hands so that I can unmute that person and discuss one-to-one with that person. So please raise your hands to get unmuted. I got one person who has asked to unmute, and the name is Sridhar. Dr. Sridhar, we are sending you an unmute invitation. You have to accept that unmute invitation, and upon accepting, you have to say hello.
Hello, good evening, sir.
Yeah, good evening. You are audible.
Actually, what is mean by the dynamic range in the settings and how it is used to get clear image, or in what conditions we should use it appropriately?
Okay. Anything else? Anything else?
Regarding dynamic range, I want to know, sir.
Okay, that. So see, Dr. Sridhar, you are right.
Yes, sir.
You have to first clear what is a gain and what is brightness.
Yes, sir.
Okay, so like in our TVs, we are having brightness and we are having contrast also.
Yes, sir.
This brightness and contrast is there in your machine, but there is no knob on your machine, on your control panel, to set that brightness and contrast.
Okay.
That setting is in the software. So that brightness and contrast will be set by your specialist engineer whenever the machine is installed. Or if you want to change the brightness and the contrast, you have to contact your application specialist and he will guide you how to go to that brightness and contrast. That brightness and contrast is same whatever is in your and my television. That is one thing. Before jumping on to the dynamic range, you should understand what wire is. Then you will understand the dynamic range. Now the second thing is gain. Okay, now you are now clear with what is the contrast and what is the brightness. Now,
Yes.
Now the gain you can increase and decrease, but when you are increasing the gain, the sharpness of the picture is not increasing. Sharpness, please pay attention to the word sharpness. The machine is, you are increasing this gain. By this gain, the overall gain of the monitor will increase or decrease, but the sharpness of the picture will not be there. Sharpness, I am repeating for the fourth time, if not a fifth time now.
Yes.
The sharpness, for example, there is a calculus. If you will increase the gain, the sharpness, the contours of the calculus will not get sharp, but you will see it more bright. That is gain. Now, what is the dynamic range? That is your question. Now, with dynamic range, the sharpness of the picture is increasing. So, whenever you want to see very precisely where from the calculus is starting, then you have to set, you have to increase. I will not say increase, I will say adjust the dynamic range. So dynamic range is to increase the sharpness of the picture. Okay. Yeah. Anything else? Please mute your microphone so that I can take the second person.
Thank you, sir.
Second person, yeah, welcome. Second person, please raise your hands. Not the physical hand, I am repeating. There is an option, more option. You have to go to the more option. You have to select the raise hand, and upon selecting the raise hand, a pop-up will appear. We will unmute that person. So Dr. Swati. Dr. Swati has raised the hand. We are sending you the unmute invitation, Dr. Swati. Upon accepting, please say hello.
Hello.
Yes, Dr. Swati, you are audible. Put your question, please.
Sir, I'm not able to focus on the uterine arteries. How to focus them properly? Usually, term patients or after 28 weeks or so.
Okay, so to focus the uterine artery. No. Have you completed the color doctor course? Yes or no?
No, sir.
No, this is the point. You have not taken the color Doppler course, or you have not completed yet the color Doppler course, and you are putting a question of color Doppler. In start, I requested to post the question from what is complete or what is about to complete. You have not completed the you have not even started the color Doppler course, and you are putting a question which is irrelevant for this point of time. But you have raised the question, I have to reply. So, but make sure, please and please, first complete the course, because this question will be already answered if you will complete the course. It is there in the course. So if you want to see now the reply, if you want to see for the uterine artery, forget about uterine artery for 30 seconds. Focus on a bigger vessel, and that is iliac vessel. Now, Dr. Swati, your name is Dr. Swati, right?
Yes, sir.
Dr. Swati, are you a gynecologist?
Yes.
Yes. Now this will be very lengthy because this is not the answer. This is the explanation itself. Where is the uterine artery? Is uterine artery at the level of uterine fundus? Is uterine artery? No. Listen to the point very carefully. Is uterine artery at the level of the fundus? Yes or no?
No.
No. Is uterine artery at the level of the body of the uterus? Yes or no?
No.
Is uterine artery somewhere at the level of the isthmus?
Yeah, it's at the cervicouterine junction.
Yes. So the uterine artery is somewhere at the level of the isthmus. Now, where the probe should be? The probe should be just above the pubic surface. Now this will be the bladder. I will be very brief because this will take about 40 minutes, because this is not the question. This is the complete topic, how to scan the uterine artery. That is already included in the color Doppler. So what I will request you to first complete the color Doppler, because these things are already discussed in great detail over there. Now the point is you have to see for a bigger vessel, and the bigger vessel is iliac vessel. So when you see the iliac vessel, you will be seeing a crossing vessel over there, and whatever is crossing, that has to be the uterine artery. That has to be a uterine artery. So the basic important point is that whenever you are looking for a uterine artery, before jumping onto the uterine artery, see for the iliac vessel, and then see for a crossing vessel. The crossing vessel has to be the uterine artery. Now, how to confirm whether I mean iliac vessel or not? This is in detail in our course. The iliac flow, the triphasic flow, the typical triphasic iliac flow you will be seeing from the iliac. Now from the uterine, you will see a uterine flow with a diastolic flow or maybe a notch. Now when there will be notch, how much will be the diastolic flow? That is in the that is in the fetal color Doppler course. In fetal color Doppler course, we are having more than 3 classes on this point, whatever has been raised, how to focus on the uterine artery. So I gave you the brief that the uterine artery is crossing the iliac vessel. So better not to jump onto the uterine artery, but first see to the iliac vessel. But here is a point that The ureters are also here. Now see, the ureters are also here. Now you should not get confused between the ureter and the iliac vessel. Now on putting the color, the iliac vessel will take color, whereas if you are dealing with the ureter, it will not show you color. So these are some very basic important points to scan the uterine artery. Now, one more important point. There are many important points which we are taking in our course. Now, whenever the probe has been put, it should be from the other side so that the beam is hitting through the bladder, So this is not the complete answer, because the complete answer we are having some 3-4 classes, as already said, in fetal Doppler. Anything else?
No,
Next
sir,
person,
thank you.
please. Anything else, Dr. Swati? Any other question related to your course, whatever you have completed? You have not completed yet. You have not yet started the color Doppler, and you are putting a question from color Doppler. Post a question from whatever is complete till now. Okay. Dr. Swati, if you don't have any question, I am muting your computer.
Okay, sir.
Okay. Now there is one more person who is raising the hand, and his name. Now see, the person is not mentioning the name, because upon joining you have to mention your name so that the correct name will appear over here. Now, what is the name reflecting in the system is doc checks. DOC, then there is space CHAKS. So most probably it is Dr. Checks. So whosoever is Dr. Checks, we are sending you an invitation. And Dr. Kirti also has raised the hand. We are unmuting you in a while. Dr. Checks, say hello.
Good evening, Dr. Chakshu here, sir, from Uttarakhand.
Okay, Dr. Chaksudeep.
Maybe my Zoom is picking up my short name.
Next time. No, not Zoom is speaking. You have filled as Dr. Checks. So next time, please. Okay, it is now clear
I'll
that
correct
you are
it,
Dr.
sir.
Chaksudeep. Okay. What is your question?
So we are having our exam tomorrow, theory and MCQ.
Okay.
Any specific tips, sir, which you can give, because our course is still not covered and we are just brushing up with the
which exam you are having?
The CBT exam, Uttarakhand.
Uttarakhand. And you are registered with us for the CBT exams, crash course,
Yes, sir.
I mean.
Yes, sir.
And when you have started?
Sir, I have started around 25 days back only.
Only 25. This is the point. This is the point, that you have started just 25 days before. And you yourself know how deep ocean this ultrasound is.
Yes, sir.
And now, in a span of 20-25 days, it is next to impossible to complete whole of the course. Now you want me to say, how can I help you? How can I help you? I can help you by sending the books, which is already with you, most probably.
Yes, sir. No? I have the books.
You have the books.
I've gone through your 4 modules.
But
yes.
The exam is tomorrow.
Yes.
So the point is that there will be questions from physics. There will not be more than 3 questions from physics. Not more than 3 questions from physics. And there can be 1 or 2 questions from color Doppler.
Right, sir.
Don't worry, the peripheral Doppler will not be touched over there. Right, but the fetal color Doppler, yes. And we are having, that is why we are having the fetal color Doppler, not the peripheral color Doppler in our course. Okay. This MSK, they will not touch. They will not touch. So the tip is that, what should be the tip? The tip is that
the exam is consisting of 50 MCQs and 10 short notes, 5 marks each. Yes.
Don't worry, if you will go through the MCQs, whatever is sent to you, I mean, whatever is in the books, go through those MCQs and these short notes, you will crack the exams, no worry. But there is, I don't have any magical stick, to show you that you will pass the exam. You haven't have to play with your neurons. Think more, before hitting any point. So if you have any specific question, you can put over here so that I can reply that specific question.
Sir, I haven't gone through the Doppler module. So
forget about Doppler module. Forget about Doppler module, because the Doppler module will take you about 10 days, if not more. And there will be not more than 2 questions from Doppler module. That is what I told you. The Doppler, the questions from the Doppler will not be more than two. But gallbladder, yes, there will be early pregnancy. There will be ectopic, maybe that they will not touch, but early pregnancy, yes. Gallbladder, liver, pancreas, spleen, yes. Retroperitoneum, maybe no. So these are the important topics: gallbladder, liver, pancreas, spleen, kidneys,
right,
prostate from abdomen, and from this gynaeops, the uterus, with the ovaries. That is our male pelvic ultrasound course. Then
right.
early pregnancy with ectopic, you can skip. You can skip because it is tomorrow exam. You can skip the level 2nd, but
Right.
Fetal well-being, yes, fetal well-being, we are having 1 class, so go through that fetal well-being also. Okay, so I'm wishing you the luck. So please update about your exams day after tomorrow in the group. Dr. Kirti, we are sending you unmute invitation, and Dr. Gaurav also. So whosoever will join, Dr. Gaurav has already joined. Say hello, Dr. Gaurav.
Hello, sir.
Yes, hello. You are audible. Please put your question.
Sir, I have question regarding Doppler videos. In one of the chart which you gave us for the RI value of umbilical artery, there are two charts.
There are two charts. 2 charts of what?
RI value of umbilical artery, reference values.
Wait, let me open the PPT so that we can see what where is. See, merely posting in the WhatsApp group and discussing one-to-one, this is more effective. It should be here. So this is the heavy file. It will take about 30 seconds. It is already open. Yeah. This one?
I can't see, sir, on my screen.
You can't see on the screen. Show me the screen. It is there. It is there on the screen. Probably what you have.
Yeah, this one, sir.
Yeah, yes, this one now.
Yes, sir.
What is the point over here?
Sir, in the left umbilical artery RI index chart, the values are from 1.80 to 0.60
to 0.80, right?
Yeah. Yes, and on the right is from 0.8 to 0.6.
Okay, now see, the confusion is that this is normal. Now see, this is normal, but you are not paying attention to this. This is abnormal. Here, everything is covered. Abnormal. Now see, red is in abnormal. Abnormal with normal. So this is normal, this is normal, and this is abnormal over here. Over here, the covered part is the normal with the blue color, but you are not paying attention to this line which is going up, and this is abnormal. Now see, if you will draw a line over here, what that line will go? It will again hit up to 1.5, and this is that 1.5. Same. So these are same. These are same. But the point is, this is normal over here, highlighted normal. You are not paying attention to this red line. And if I will draw another line from this top of the abnormal, it will again go to the 1.5 or 1.6.
Okay, sir. I mean, according to, if we see gestational age is 35th week.
35th. Let me go to the 35th week. Okay, 35th week. Okay.
And umbilical artery RI value comes around 1.1.
1.1, somewhere here. Okay.
Yeah. Will it be normal or abnormal?
Okay, now let us see. Now see, the point is that you have to understand the 10th percentile and 90th percentile. The 90th percentile is over here, and if your RI is crossing the 90th percentile, then it is abnormal. Then it is abnormal. So 1.1, now see, 1.1 is absolutely normal because this is fitting over here. And over here, now see 35. Let me go to the 35th week. Okay, here the 35th is over here. So 1.1. Now see 1.1 over here is going to the abnormal. Now, this can be normal. This can be abnormal. Why can? Why I'm using the word can? Now 1.1. Now see, why is 1.1? 1.1 is over here. It is in the bracket, but it is on the upper side. That is, it is touching the 90th percentile now. Now, what is your name?
Dr. Gaurav.
Dr. Gaurav. Dr. Gaurav, what is your height?
5.8.
5.8. I am 6.2. What is your age?
Sir, around 36.
36. Okay, for the sake of argument, let maybe also 36. I'm not, I'm a bit more. Who is normal height wise? You with 5.4 or me with 6.2? Who is normal?
Sir, I am normal.
It means that I am abnormal. Am I abnormal with 6.2? 6.2?
No, sir, they both are normal.
Both are normal. Now see, you are getting the point. Both are normal. But the point is how much height one should have at 36 years of age. How much?
Sir, full height.
Full height.
One
What do you mean by full height? 6.2 or 3 or 4.5?
Sir, some can have
This is the point. This is the 10th and the 90th percentile of any chart. You're getting the point now? Now, another example. There are twins, Ram and Sham, Sita or Gita, dichorionic, diamniotic. I'm repeating, dichorionic, diamniotic.
Yes,
twins. Twins means the genetic code is same. Yes. Will you expect both to have same weight at the age of 30 years or at 10 years? Yes or no?
Yes, sir.
Will you expect same weight in both twins, dichorionic, diamniotic?
Yes, sir.
No. Yes or no? Think. Sham is having 40 kg of weight at the age of, say, 30 years. No, 30 will be much more. Let us take 50 kgs. 50 kgs at the age of 25. But the other twin is having 55. Who is normal?
Sir, one is having a 50 kg and another is?
Another is 55.
Both, sir, are normal 5 kg.
Now, listen to me carefully now. If you will expect that discordancy of weight in a twin fetus, not in a fetus now, in a twin babies, why you are not expecting that one fetus may have a bit low of the diastolic flow and the other may have a bit high diastolic flow, but both can be normal. But the point is, if one baby is having 180 kg, that is absolutely abnormal.
Yes, sir.
Now, coming to this 1.1, I'm very sorry that my answers are very lengthy. Now see, 1.1. 1.1 is fitting over here, but it is not crossing this dead line. It can be normal, but it can be abnormal also. Now, to say whether 1.1 is normal or abnormal, what I have to see? I have to see for the redistribution of flows. If with umbilical artery resistive index of 1.1 and there is a brain sparing effect, it means that this is not normal for this fetus but abnormal, because I am seeing the redistribution of flow. Are you getting my point? Yes or no?
Yes, sir.
This is the point. One artery, one vessel is not giving me the diagnosis, but the two or more vessels interpretation is making the sense. So I cannot say, nobody in the world can say whether 1.1, because 1.1 is in between the 90th and the 10th percentile, but on the higher side.
Yes,
normal or abnormal. I cannot say, but pay attention. But if it is 2, now see, if it is 2, it is 101% abnormal, but 1.1 is not fitting neither abnormal nor normal. Why not normal? Because it is touching this red line. So this is very important, because you have to make this point once for all. You cannot make any diagnosis by one vessel. You have to see other vessels. And here, if the umbilical artery resistive index is on the upper side, then I have to see for the middle cerebral artery. In addition, I have to see for the aorta also. Now the whole of the interpretation comes in role. Okay. Anything else?
Yes, sir. Two more questions.
Yeah, tell me.
Sir, one is the how to diagnose fetal anemia from MCA Doppler.
Okay, MCA Doppler. Okay, we have already over here, middle cerebral artery. Where is the middle cerebral artery? It is here. Now, this is the MCA. Oh, sorry, this is not MCA. This is the, let me go to MCA. This is MCA. Now, what is your name? Sorry?
Dr. Gaurav.
Dr. Gaurav. Dr. Gaurav, are you able to take the MCA flows? Yes or no?
Yes, sir.
Now there is something which is called as systole, and there is something which is called as diastole, and there is something which is called as peak systolic velocity.
Yes.
What is a peak systolic velocity? What is the peak systolic velocity?
Sir, peak systolic velocity is the maximum velocity of the systolic component.
Okay, done. Now I am showing you with this pointer over here. This is the peak systolic velocity over here. What is this over here? What is this? 20, 40, 60.
Velocity chart, sir.
Velocity. So this is the velocity range over here. Now, yes. Coming to your question. I first have to see the peak systolic velocity, and then I have to see the velocity range. Velocity range. If, now listen to me carefully. This is the answer. If the peak systolic velocity is crossing 80, then it is due to the fetal anemia. If it is in between 60 and 80, that is borderline. So what is normal over here is below 60 or touching 60. Now see over here. How much is the systole over here? Peak systolic velocity, not the systole. 60. Now, if this peak will be at 90 or more, that is abnormal. Now, in fetal anemias, I have to see for this peak systolic velocity. And if the peak systolic velocity is crossing 80, now please note it. If it is crossing 80, then you are dealing with the fetal anemia. And if it is in the bracket of 60 to 80, that is borderline. And in normal, it is not crossing 60.
Sir, at any gestational age?
No. Now we are having charts. Now we are having charts like RIPI. We are having charts now. Now you have to see that chart. That chart will tell you how much peak systolic velocity you should have with this gestational age. That is why I gave you something which is called as borderline. if you will memorize, now see, every time you cannot go to a chart. It is near to impossible, Dr. Gaurav.
Yes, sir.
Be practical. It is near to impossible to memorize how much the peak systolic velocity should be at 25 weeks, how much it should be at 27 weeks, how much it should be at 32 weeks. It is next to impossible. Now, either you should have a chart which can be there just in front of your machine, so that you can go to that chart every time, or you have to be very broad, and that broad is that. Just hold on, Jyoti, come here. What is this? Yeah. Now the next question was how much should be the peak systolic velocity, and is it varying with the gestational age? Yes, it is varying with the gestational age. For that we have charts, but if you will memorize that crossing 80, that is applicable for each and every gestational age week. But if you want to be very precise, then you have to download a chart that is over there. Then paste that chart in front of you. You will see how much peak systolic velocity you should have with this gestational age. But if you will memorize 80 and above is abnormal for each and every gestational week, the weeks of gestation, you will come to know that it is absolutely yes in the chart also. Anything else?
Okay, thank you. That's all, sir.
Okay.
Thank you very much.
Welcome. Yeah, next candidate, please mute your microphone. Whosoever has posed the question and has got the answer, so please mute your microphones. Dr. Kirti, we are sending you the unmute invitation. Say hello.
Yes. Hello, sir. Can you hear me?
Yeah, you are audible.
Yes, sir, I can hear you. So, sir, I have completed the early pregnancy module. However, I have few questions which are very
Please go ahead.
basic.
That is why we are here.
Yes, sir. Sir, the modules were excellent, but we haven't been taught as yet, or maybe I have missed it, how to measure the gestational sac diameter, the CRL, the yolk sac, and in which planes, how to make the probe movements for such measurements. So would that be taught in practical classes when we come down on site, or how are we on those things?
Got your question. I got your question. Now, the first point is how to measure a gestational sac. Now, what is your name? Dr. Kirti, right? Are you Dr. Kirti? Say yes or no.
Yes,
what is your name? Okay. Dr. Kirti, are you a gynecologist?
Kriti. Yeah.
Kriti. Okay,
Yes,
sorry.
sir.
Kriti. Are you a gynecologist?
Yeah.
Yeah.
Yes, sir.
How to take the volume of anything. Anything means anything. Be it a room, be it a gestational, this sac, anything. How to measure a volume? What is the formula to calculate the volume? And not now the doctors. Now we are going back to the 8th standard. What is the volume formula of volume? Please don't take the otherwise. I am just making the things clear.
So length into breadth into height.
It means, right. It means you have to take the length, you have to take the breadth, and you have to take the height also. To take the volume of anything, be it your chamber and be it the gestational sac. Clear up to now?
Yes. Yes, sir.
Now to take the volume of anything, we have to have length, breadth, and height. Then we have to divide it, but the point is that we should have length, breadth, as well as height also.
So
yes.
Sorry, your voice is a bit muffled. The network is breaking.
No, network is not breaking. Let me check with the audio. Just hold on for 1 second. Can you see the whiteboard also?
Yes, sir, it's visible.
Now we have to take the volume. If we are taking the volume, we should have length, breadth, and height. Now Now in your machine, these things are in physics and machine settings. Have you completed the physics and machine settings? Yes or no?
Yes, sir, I have.
Yes, sir. Okay. Now, if you have completed, maybe that you have skipped this class over there. So go back to that. But I am taking some important points over here. Now there is a setting in your machine which is of dual. What for is that dual image over there? Dr. Kriti, there is a dual image.
Yes, dual
What
image
for?
is there,
What
right?
for is
I
that?
know.
To save your
To
paper?
measure,
No.
no, for the volume purpose.
For the volume purposes. Now, how to measure a gestation? In gestational sac, your machine may ask for MSD. Is it asking for MSD? Yes or no?
Yes.
Or it is asking for GSAC.
Yes.
Now, you have to see to your machine. If the machine is just asking for GSAC and upon pressing onto this GSAC, if the machine is asking for one measurement only, listen to me carefully. If after pressing the GSAC, the machine is asking for one measurement only, then you have to give one measurement only. But upon pressing the gestational sac, or if there is a MSD, the machine, if asking for three measurements, then you have to give three measurements. Now, what are the three measurements? Three measurements are of volume, length, breadth, and height. Now, Dr. Kriti, where can I take the length? In transverse section or in longitudinal section? Don't tell me that this is not in the course. This is very much
So
detailed in the course.
longitudinal.
Longitudinal. Now see, in
Longitudinal.
length will go to the longitudinal. The breadth? The
Breadth in
in
transverse.
transverse. And the height in transverse also. Now,
Transverse.
the point is,
Okay.
whenever I see a gestational sac and my scan plane is transverse, and put on another side the longitudinal one. So this will be, one will be longitudinal like this, and another will be more oval or round. So this is transverse. Now how to measure? First, see to, I am repeating, whether the machine is asking for one measurement or three measurements. If it is asking for three measurements, then you have to measure from here to here. That is first one. You have to measure from here to here. That is the second one. And one from here to here. That is the third one. Now you have given to machine length, breadth, and height. Then a pop-up will appear here with the gestational age. This much is the gestational age. But the basic important point is that you have to see to your machine whether the machine is asking for one or three measurements. And now, whether to measure inner to inner or outer to outer, you have to measure here outer to outer. I mean that whole of the gestational sac. And when you are measuring the yolk sac, again, you have to measure the whole of the yolk sac. Whole of the yolk sac, including the walls, because the walls are very, very thin if it is a normal yolk sac. If it is a calcified, then only it will be increased. So this way, we are taking the mean sac diameter. Now, you have completed only early pregnancy, yes or no?
Early pregnancy and physics.
And
yes,
physics.
and some
Not
part of
not
fetal
the fetal
biometry.
ultrasound yet.
So I've started doing it. The head part is over. Abdomen, placenta, AFI is remaining.
Okay. So anything else you want to discuss right now?
Yes, so CRL, how do we measure?
CRL. Now, to take the CRL, the fetus should be in a neutral position. What I mean by neutral position? By neutral position, I mean the head. Now see, this is the head, this is the crown, and this is the rump. I have to measure from here to here, but the story is not ending here. But now see to my head. If I will flex my head, extend. what will happen to my complete height? Will it increase, decrease, or remain same? If I will elevate my chin, am I increasing my height or decreasing, or it will remain same? Increasing,
it will increase. So yeah.
Now this fetus is also like you and me. If he will flex, if the neck is extended like
so
this.
again, the voice is breaking.
Wait. No, it is not from our side now. Maybe that your network is dropping. Now, if the chin is elevated, it means that you are dealing with an extended fetus. With an extended fetus, the CRL will be more, less, or it will not change. With an extended neck.
So it will be more.
More. Now, if the fetus is in flexion, it will be less. Yes or no? Now to take a CRL, the fetus should be in neutral position. Neutral. Now, what I mean by neutral, you have to see to this chin. If the chin is touching the chest, then it is flexed. If the chin is extended, going up, then it is extended. Now, how much the chin should be? Now, see to your chin, my chin, and tell me how much angle the chin is making with the neck. Approx. Is it 90 degree? Approx. So same you have to see to the fetus also. The fetal chin should not be dropped up to the sternum. And if it is dropped like this, then don't take CRL if the fetus is flexed. So this way we are taking these CRLs from.
Okay, so then how do we keep the probe? It should be transverse. Section.
No.
For the CRL.
No. See, you are a complete fresher probably, right?
Yes, sir.
Yes. Now, see, whenever the transverse and longitudinal is taught to you, the transverse and longitudinal is with respect to the body, not with respect to the organ. Are you understanding this slide? Yes or no?
Yes.
101%
yeah. It's
or
with
99%?
Respect to the maternal body.
Yes. It is with respect to body. Now, can you open your camera? Yes or no? This is optional. Can you open your camera?
Just a sec. Yeah, sure.
Open your camera.
Can you see me? I don't know
Wait,
how to open.
Dr. Kriti, adjust your camera towards and focus it properly. Yes, you are there. You are there. Now,
how to open the camera?
Open. It was open. It was open. Now you have closed it.
Switch camera. Yeah. Oh, sorry, sir. Now, can you see? I'm not sure.
Now I can see. Now I can see. Yes.
Oh,
now I can see
okay,
you.
Sir.
Now the point is, see to me. I want to make contact with you. Now, Dr. Kriti, see to me.
So sorry, I can't hear you.
Your network is slow, but we will make it out. We will make it out. Pancreas is like this in the body. Now see, pancreas is like this in body. Yes or no?
Don't believe 1 minute, I cannot see the screen.
Wait. Now see,
sir, no, I cannot see your screen.
Pancreas is like this in the body. Yes or no?
Sir, I cannot see the screen. I don't know why. Okay, yes, sir, now I can see. Yes, sir, sorry.
Please
yes, I
don't mess up with these knobs over there. Please don't mess up now. Now the pancreas is like this in the body. Yes or no? This is the pancreas.
Yeah, right.
Right? Now, listen to me. When I will be putting probe, assume that this is the probe. On this pancreas, this probe is in transverse section with respect to body. Yes or no?
Yes, sir.
Yes, but the point is, when I am putting it transversely with respect to body, what I will expect from pancreas. I mean, which slice I will be seeing of pancreas, long or short? I mean,
So,
longitudinal or transverse?
So transverse.
Wait, again, now see again. Wait. This is the pancreas. I will not let you go till you will not be 101% clear. You are not clear. Now this is the pancreas. See over here. Now I am putting probe over the body like this. And this probe with respect to body is transverse or longitudinal? Like this.
So transverse.
Transverse. Is
transverse,
this transverse plane transverse for pancreas or longitudinal for pancreas?
So it is transverse for the pancreas.
Wait, let me take a bigger monitor. So I'm pinning the video. Now see, the pancreas is vertical or horizontal in the body, inside the body, vertical or
horizontal.
Horizontal. Now,
horizontal,
if I will put probe like this in transverse fashion with respect to body, will this pancreas, will I cut this in long axis or in short axis?
So long axis.
Long axis. Now you are coming on track. It means that I am seeing with my eyes that this probe is transverse with respect to body, but I am taking the length of the pancreas. Why? Because the pancreas is not vertical, but horizontally placed in the
pancreas
body.
Is transverse.
Right? Now, this is applicable for each and every organ and each and every slice. Now the question, what was the question? What was the question? The question was,
CRL,
when I am taking CRL, should I take longitudinal or transverse section? Now, if the fetus, now listen to me carefully. If the fetus is standing like this in the body for that particular point, then the probe should be like this.
Yes longitudinal.
No? Yes or no?
Yes.
But if the fetus is lying like this, lying down, then should I keep it transverse or longitudinal with respect to body?
Transverse.
Now you tell me how the fetus is lying in the uterus.
So usually it's
90 degrees all times with respect to body, or 0 degrees all time, or 360 degree all times? How much is the degree wise? Tell me.
So usually CRL babies
no, forget about CRL. Only. Tell me how the fetus is inside the uterus with respect to body. Is it always
longitudinal? Mostly longitudinal. Yeah.
Mostly longitudinal. Now, Jyoti, go then. I'm having all gadgets here to make you explain. Now see over here. The fetus. This is the fetus. Now, if fetus is standing like this, then my probe has to be this way every time. Yes or no?
Right.
But if it is this way all times, then my probe has to be like this to take the CRL. Now, I don't know any fetus who is standing at 90 degree with respect to body or lying like this every time. I don't know what the fetal position is for this particular point of time. It will change. It can change over 1 second only. Fetus is like this, like this, like this, like this, like this, like this. I have to now see to the fetus. Now I have to forget about They probe how the probe is placed onto the maternal abdomen. Now, the fetus will decide. Now, this baby will decide whether the probe should be like this, like this, like this, like this, like this, like this, or like that. Now, you have to take this transverse and longitudinal with respect to body, and you have to throw that concept in dustbin. Because if you will stick to that transverse and longitudinal with respect to body, you will never be able to do any ultrasound. That transverse and longitudinal is with respect to body, just to make you understand what is transverse and what is longitudinal. Now, this baby, if like this, listen to me carefully, if like this, and it is in my body. Now see, it is in my body. I am putting probe transversely, but I am cutting this fetus from head to toe. Yes or no? So this transverse section for this particular point will be a long axis of the fetus. Yes or no?
Yes.
But the slight movement from the fetus will change this scan plane. Then, so now you have to rely on the monitor. Till the time the fetus is not in complete length, you will not see to your hand. Why? Because if you will see to the hand, then you will stick to what is taught, the transverse like this and longitudinal like this. So the point is that this transverse and longitudinal is with respect to body. But when you are taking these fetal ultrasounds, you have to rely completely on the monitor. The monitor will dictate you whether this is a long axis or a short axis of the baby. I hope that you have got your answer, right?
Yes, sir, it's clear. So one more thing for the gestational sac measurement, you said we take only one measurement. So which measurement is that
I
which we
did not
take?
tell you we take only one measurement. I told you if the machine is asking for one measurement, then you have to give one measurement only. But if the machine is asking you for 3 measurements, then you have to take those 3 measurements which we have discussed now. What the point should be there in your mind, if the machine is asking for one measurement only, which measurement has to give to the machine? Yes or no?
Yes, sir.
Yeah, I can smell your mind distantly now. Now, it cannot be complete transverse. It cannot be completely length. It should be somewhere in between the length and the transverse section. It means that it should not be the longest diameter. It should not be the shortest diameter. It should be in between the long and the short axis. Anything else?
Yes, so one more thing, how to measure the RPOC?
RPOC. Okay.
Yeah.
Wait. Give me the liver. Where's the liver? Let me take the kidney. Now, RPOC is always and always around. Yes or no? I will confuse you to make you understand. RPOC is always and always around. Yes or no?
Yeah, mostly.
No, not mostly. Listen to the options. Words very carefully. RPOCs are always and always around. Yes or no?
Yes.
No. Why RPOC will be always round? Now, RPOC is always and always oval. Yes or no?
So it can be any shape.
Yes, this is the point. Now, the point is, if the RPOC is always and always round, then I can say that I have to take the transverse section, then I have to measure from head, not from head, anterior to posterior and from right to left. It is not always round. It is not always. So there is no fixed shape of any RPOC. Now, assume. Forget about the organ, see to the shape. This can be the shape of the RPOC. This can be the shape of the RPOC. Now, first, what you have to do, you have to take the longest diameter. The longest diameter measurement will be from here to here. Yes or no? And the shortest will be from here to here. Yes or no?
Mm-hmm.
So
Mm-hmm.
you have to take two measurements there, the longest one and the shortest one. Then you can give the measurement. Don't give only one measurement. Why? If you will be giving one measurement from here to here, assume that this is 20 centimeter, 20 millimeters, 20 millimeters this, right? But if you will be scanning that patient tomorrow, now let us take the shortest diameter of this RPOC. If it is 12 from here to here, and today you have taken it from this point to this point, see to my fingers, two fingers, it is 12, 1 to 12 millimeters today. And tomorrow, the patient is bleeding, or you have given some medicines, and the patient is getting rescanned after 2 days or 3 days. Now you are hitting with your plane to the longest diameter, and from here to here it was 12, and from here to here it will be more. Then what will you think? If it is not coming now 12, you will think that how the RPOC is growing despite of my medications and all these things. But actually, it is the measurement which is telling you that this is the long section of this RPOC. So that is why I am telling you to give two measurements, 12 and 21. And this way you have to give measurements to any RPOC. Don't stick to one measurement only. Give the shortest and the longest one. Anything else?
Okay, sir. Sir, I have a couple of more doubts, if I may, please.
Yeah, go ahead.
Sir, how to differentiate whether the thing we are measuring is the femur or is it the tibia or fibula?
Okay. Now, don't take this otherwise. Why you are not seeing to this fetus like a human being, you and me also? Why you are thinking that this is some alien or a robot over there? How many femurs you are having in one leg? One or two? One. How many tibia and fibulas you are having?
Two.
Two. Now, if you see two bones running parallelly, that has to be tibia and fibula. If you see only one bone, then it is femur.
Okay.
Okay. Anything else?
No. Thank you so much, sir.
Yeah, you can go ahead with as many questions as you want. No? Done? Okay.
Okay. Yes, sir. Thank you.
Okay, welcome. Please mute your microphone. If anybody else wants to put any question, most welcome. Otherwise, we'll wind up. Waiting for any question. So I'll be waiting for 1 minute. Show me the comment box if there is any question. So you can post in the comment box also. I told you, sir, can uterine prolapse, uterine descent and cystocele? How? Sir, can uterine prolapse, oblique uterine descent and cystocele? How? Okay, then he has changed the language. Sir, can uterine prolapse, oblique uterine descent and uterine cystocele be diagnosed and how? Now, yeah. So the question, keep it here. So the question is that can we diagnose the cystocele and the uterine prolapse? Uterine prolapse, I will say it is very difficult to diagnose on ultrasound. It is very difficult. You have to be very much technically, you should be very strong, and that too it is not on TAS, it is not on TVS, but it is on transperineal scan. So first you have to learn the transperineal scan. The uterine prolapses cannot be diagnosed on TVS. These are very difficult to diagnose on TS, but translabial or the transperineal scan, these are same, translabial and transperineal. Yes, we can diagnose, then we have to see some lines over there. But first, try to get the translabial or the transperineal scans. So these uterine prolapses are can be diagnosed on transperineal scans only. Now, the second part of the question is the cystocele. Now, if the anterior posterior diameter of the urinary bladder is more than the right to left, then it is the cystocele. So actually, what is that cystocele? Cystocele is nothing but the herniation of the lower part of the bladder down. And if it is herniating down, how it will look like? It will look like, let me take the whiteboard. What is wrong with this? So if I see the urinary bladder, this urinary bladder is more oval. So the right to left, you see the right to left diameter and this anterior posterior will be almost same. Almost, I'm using word, but in case of the cystoceles, I will be having more depth over here, more depth. So if I am having more anterior posterior than a right to left, then I am dealing with the cystocele. So this way we can make out the cystocele. Next question. Next question. Comment box. Please, sir, what about the case posted fetal echo? Now, fetal echo. Yes, we are having a course of the fetal echo also, but that is not available on website. We are about to upload that on our server. So very near future, you will get the fetal echo also. So importance of what is the question now? What is the question? I cannot see more questions over there. So please post your questions. Please post your questions in the comment box very fast, please. We are running short of time. Dr. Zaitoon has raised the hand. Okay, let me take Dr. Zaitoon because I am not getting any questions in the comment box. I am asking to unmute Dr. Zaitoon. Dr. Zaitoon, we are sending you the unmute invitation. You will be the last person to join today. Dr. Zaitoon, please say hello. Hello. Your voice is cracking. Dr. Zaitoon. Now see, there is only one connection between you and us, and that is internet. If you don't have a good network connection, it is next to impossible to get connected. So please have a good network connection whenever you are joining any live session. I am unmuting the doctor that Dr. Zaitoon, but due to the network, I'm not able to hear her voice. Dr. Zaitoon, say hello. No, not audible at all. So this was all for now. See you very soon. We will send you the invitation of next interactive session in your WhatsApp. Thank you very much.